Hello everyone, in this class we will learn about pressure sores. Pressure sores are one of the complications highly susceptible to bedridden elderly individuals. Pressure sores not only affect the health of the elderly, increasing their pain, but can sometimes even be life-threatening. Therefore, understanding and preventing pressure sores is extremely important work. In this lesson, we will learn about pressure sores from 4 aspects: the concept of pressure sores, risk factors for pressure sore formation, populations prone to pressure sores, and the stages of pressure sores. 1. A pressure sore is local tissue damage and necrosis caused by prolonged pressure on a specific part of the body, which impedes blood circulation, leading to persistent local tissue ischemia, hypoxia, malnutrition, and consequently, the loss of normal tissue function. It is also known as a pressure ulcer. 2. Risk factors for pressure sores include formative factors, contributing factors, and related factors. Formative factors directly cause pressure sores and include pressure, friction, and shear force. Among these, pressure, referring to force from the body's own weight and externally applied forces, is the most important causative factor. When external pressure exceeds capillary pressure, blood flow in capillaries and lymphatic vessels slows down, leading to insufficient oxygen and nutrient supply and poor excretion of metabolic waste, which can easily cause tissue degeneration and ischemic necrosis. Irreversible damage can occur when skin tissue is subjected to pressure greater than 69 millimeters of mercury for more than 2 hours. For example, surgical patients subjected to continuous pressure for over 1 hour have the potential to develop pressure sores. Friction is easily generated when a patient's skin is dry and wrinkled, the bed surface is uneven, or bed linens are damp. It removes the protective keratinized layer of the outer skin, increasing the skin's sensitivity to pressure, and can directly lead to skin congestion, edema, bleeding, inflammatory changes, and dermal necrosis. Shear force is an external force parallel to the tissue surface. Because shear force can twist, change the angle, or even completely close off blood vessels, it affects local blood supply and can cause tissue necrosis. Shear force most commonly occurs when a patient is in a semi-Fowler's position. When shear force is present, even low pressure applied for a short duration can cause ischemic damage to the skin and soft tissues. Contributing factors promote the formation or worsening of pressure sores to a certain extent, mainly including the following factors. Sensory impairment can cause the body to not respond to harmful stimuli. Sensory impairment combined with decreased mobility is a primary cause of pressure sores in paraplegic patients. Limited mobility refers to the impaired ability of a patient to independently change position. Limited activity or mobility prolongs local pressure time, increasing the chance of pressure sore occurrence. Malnutrition leads to reduced subcutaneous fat, muscle atrophy, and weakened regulatory capacity of tissues and organs for stress metabolism. Areas with thin fat tissue are more susceptible to circulatory impairment under pressure, increasing the risk of pressure sores. Moisture. In a moist state, the skin becomes soft, its elasticity and luster decrease, and it becomes abnormally fragile, susceptible to damage from pressure, shear, and friction. Excessive moisture or dryness can contribute to pressure sore formation, but the incidence of pressure sores on moist skin is 5 times higher than on dry skin. Temperature. For every 1 degree Celsius increase in body temperature, tissue metabolic oxygen demand increases by 10%. The high metabolic demand caused by elevated body temperature can significantly increase susceptibility to pressure sores. Related factors are elements that influence the formation and progression of pressure sores, including age, stress response, and other factors. Elderly patients over 60 experience decreased cardiovascular function, reduced capillary elasticity, and impaired peripheral circulation. Local tissues are more prone to ischemia and hypoxia after pressure. Statistics show that the incidence of pressure sores in patients over 40 is 6 to 7 times higher than in those under 40. Smoking, nicotine in tobacco causes peripheral vasoconstriction and local malnutrition, increasing tissue susceptibility to pressure sores. Stress. Clinically, a high incidence of pressure sores is observed in the early stages of acute injury patients. Under stress, a large amount of hormones is released, leading to disorders of the central nervous and neuroendocrine systems, accompanied by insulin resistance and glucose/lipid metabolism disorders, disrupting homeostasis and reducing tissue resistance to pressure. Others, factors such as improper use of nursing aids, uncomfortable posture, mental depression, despondency, and lack of self-care awareness are also risk factors for pressure sores. 3. Populations prone to pressure sores include those who are bedridden for long periods, have reduced activity, are extremely emaciated, have edema, are physically weak, have spinal cord injuries, suffer from chronic neurological diseases, primarily cerebrovascular diseases, have various wasting diseases, etc. The risk is higher if conditions like hypoproteinemia, incontinence, fractures, malnutrition, vitamin deficiency, or smoking are present. 4. Stages of pressure sores. Based on the development process and severity, pressure sores can be divided into the following stages. Suspected deep tissue injury, stage I, blanching erythema, stage 2, inflammatory infiltration, stage 3, superficial ulceration, stage 4, deep ulceration, unstageable. Before a pressure sore appears, the local area might show signs like pain, softness/fluctuation, hardness, higher or lower temperature compared to surrounding tissue. Once a pressure sore occurs, it first enters stage I, blanching erythema characterized by intact skin with a persistent red mark that does not fade within 30 minutes. The red mark does not blanch, turn white, when finger pressure is applied and released. Next is stage 2. Inflammatory infiltration characterized by partial thickness skin loss, purple-red skin color, subcutaneous induration, hardening, and blisters on the epidermis. The ulceration stage includes stage 3, superficial ulceration, plus stage 4, deep ulceration. Stage 3 is characterized by ruptured blisters with yellow exudate. Stage 4, deep ulceration, is characterized by local tissue necrosis turning black, increased purulent discharge with a foul odor, and infection invading the dermis, muscle layer, and even the periosteum and joint cavity. In severe cases, it can lead to sepsis, endangering life. This is the basic knowledge of pressure ulcers we learned today. Thank you, everyone.